As many of us have mentioned repeatedly throughout this discussion, the treatment of TTP is a multidisciplinary one. TTP is a condition that cuts across traditional dividing lines within medicine because it affects so many organ systems and is complicated. Commonly involved in TTP cases are an ICU team, hematology consultants, potentially involving chemotherapy nurses for administration of these specific therapies, apheresis physicians and nurses, blood bank physicians and technologists, and not uncommonly, some of the subspecialists that are required. Neurology consultants, cardiology consultants, nephrology consultants, depending on the end organ damage present, even to the point of having to coordinate around dialysis schedules and nursing. Because one cannot be on a plasma exchange and renal replacement simultaneously. It's a little tricky. So for my colleagues, I'd like to kind of pose to you the question of the observation is, what do you believe are the essential elements in maintaining a multidisciplinary approach towards the treatment of this TTP entity?
I echo what you say. It's certainly a multidisciplinary approach to care involving multiple specialists, both hematology, potentially intensivists, the blood bank, potentially nephrology. What I think is very consistent across all institutions is that it's a multidisciplinary approach. What is somewhat unique is who really drives. You need someone driving the program. And that may be a hematologist, that may be a nephrologist, it may be an intensivist. So all parties are typically involved. You do need someone with the expertise sort of leading and directing the team in the right approach and the synchronizing what's important and when and the timing of things. What are your thoughts, Marie?
I completely agree. I think there has to be somebody driving the program retherapy, but the communication between all the different medical and allied medical groups is imperative. Now, we do need our cardiologists and our neurologists. There's nothing to do in the acute setting. The acute setting is about driving the platelet count up and trying to achieve a hematological remission. And so their role becomes very important in the medium and longer term. There's nothing they can give that's going to make things better for the patient until we get them out of the TTP situation. But it's equally important they observe patients in the acute state so that they can work with them in the medium and longer term.